Welcome to another episode of The Breakdown. Oh, kids, I've been looking forward to this conversation that we're about to have tonight for a little while because we're talking healthcare. And Lord knows there's no shortage of things to talk about in healthcare, but we're talking healthcare with I almost want to use the term unleashed here because I think this is going to be quite the conversation. Very excited to welcome back to the show former president. His term has expired of the Alberta Medical Association. He is not representing the Alberta Medical Association. He's just here talking for himself in healthcare advocacy, and I'm so excited for it. Very excited to welcome back to the show, Dr. Paul Parks. Dr. Parks, thank you so much for taking the time to chat with us tonight.
Yeah, no, thanks for having me here. And yeah, as you said, and I will repeat it, everything I say now is just my own personal opinion. I am the past president of the AMA, so still obviously involved in some formal channels, but this is just me speaking from my point of view, from lessons learned over 20, let's call it 24, 25 years of advocacy and being in the system. And then, of course, the last year as president, obviously got exposed to a lot of issues and have some knowledge from that as well. But just want to reiterate and stress anything I say. It's just my opinion. It's just me representing myself, and I know a lot of my colleagues share it, but I'm not here in any official capacity.
Do you get like a library? Like, do you get a presidential library when you for the term? Is that
I
like
wish. No, you know what? That'd be awesome. I gotta build the Parks Library. Yeah. No, don't even. You just get pretty much a thank you. So
you should at least get a plaque, I would
yeah.
think.
Oh no,
Or
we get a plaque. I get a
okay,
plaque.
well
Yeah,
there we go.
and you get the undying appreciation of your fellow colleagues, of course, right? So, no, but yeah, I mean, no one does it for the swag. They do it because they want to try to make the system better, right? So
Well, let's talk about that because last time that we had you here and you were in your official capacity, which to be clear, you're not anymore. I'm just going to
correct.
have fun with this for the rest of the night. We were talking predominantly about the, I feel like I can still call it proposed physician's pay model, particular to family medicine. That conversation was almost a year ago. You were optimistic that in the weeks following that conversation, you would see an announcement. And in that time since, we've seen Adriana LaGrange say that she has processes that she has to go through. And we've seen Danielle Smith say, look, we're in negotiations with so many people. We just can't be rolling out these things that would solve underlying and chronic problems. So, what are your thoughts on that whole experience, and do you have any hope for it going forward?
So that's a tough one. So specifically talking about the family medicine, so the physician comprehensive care model is what we propose. And just as a recap for people out there, I mean, almost every other province is moving to this, where it's moving away from just straight fee for service to a model that has some panel payment components, some time components, some visit components, more complex. It allows family physicians to do the type of care that Albertans, would think longitudinal family medicine. They know you from cradle to grave, can take care of all your issues. That other provinces, BC's done it, Saskatchewan, Manitoba, the Maritimes, like we're way behind in the country on this now. And so, it's all a blur. I don't actually recall when I came to chat with you and when that date was. It's been a bit of a blur this last, 15 months or so. But one of the things we did in June of 2023, sat down with the minister first meeting, said you have to invest in family medicine. We have to do something new. It's a foundation, family medicine, rural generalists. We have to do something creative, and we agreed, top priority. Let's get moving on it. And we did a lot of work, and we created a model. So now to get to your question, it's quite impressive that we were collaborative with Alberta Health, got the model ready to go, but it's been announced a lot by this government. In September of last year, in December of last year, there was a press conference where vaccines came up, even, and the minister and premier were both saying we're going to get this moving. Again in the around budget day, and then in March. It's just endless announcements, and so just so everybody's clear, that model's done. I don't know what the minister's saying now when she talks about processes. It was on her desk in completed form April 1. We actually had it agreed mutually, Alberta Health and IMA saying, hey, this is the plan. Are there little details we have to work out in implementation and stuff? Absolutely, but it's done. So now I don't know what processes means. I actually really probably need your listeners in Albertans to ask their MLAs, to ask the government, what the heck, what's processes? What is that now? Is that code for, we're not going to do it until the next budget, till April 2025? Is it code for, we want to get the unions settled first and then this? At one point they said they had to go to Treasury, but they've kind of backed off on that because they know they can take it to Treasury at any point. If the Premier says it's a good model to do and they're really committed to investing, they can take it to Treasury whenever they want. So unfortunately, that's a long-winded answer saying, 15 months of prioritizing this, working as hard as we can. I put up a roadmap of a lot of broken promises. And I'll say some of these were the goalposts being moved, but some of these were express promises that the minister and premier gave to the profession, to Albertans, and to family medicine specialists out there that have been holding off and saying, hey, are we going to close our practices or are we going to get some help? And unfortunately, today, sitting here talking to you, the answer is no. There is no hope for those practices right now. There's no definitive time. They keep saying they love the model, they want to announce it, but you can't pay your staff with that. You can't pay your rent and your lease and your staff and keep your offices open with we really want to do it, but we got processes. Like nobody can go on that. So unfortunately, we're tied up here now where government's making a choice not to act. Government's making a choice to not invest in primary care and in rural specialists, and it's going to be really bad for the province. It's going to hurt Albertans. So why should Albertans care? One thing that I'll tie into that, I don't think a lot of our government and MLAs fully understand that it's family medicine physicians who run our rural hospitals. They're the ones who keep our emergency departments open out in the rural. Every rural closure you see now of an emergency department that's closing or the hospital accesses are closing, some of it's related to subspecialty care, but the vast majority of it is access to family medicine physicians and rural generalists. And that's just going to domino and domino, and you're going to see more and more of those close. You're going to see them have to travel into the bigger centers. It's just going to have an ongoing vicious cycle. So it's sad that we're at this state where the government's choosing not to act.
There were some stunning numbers that were released, and I realized that they came likely after your tenure ended, but I'm sure that the establishment of the survey that got those numbers, uh, the if I was reading that right, more than half of the current family medicine practitioners in the province of Alberta are looking at exiting. Something like 72%, I think it was, are looking at exiting the profession of family medicine. And of that group, like more than half of that group has said, "Oh, and we're actively taking steps." So it. I guess the question is, there's no question that there's a crisis in family medicine. It's been well documented. It's been well discussed. We have seen the government step forward and say, but it's a shortage of all the people. There's only so many people out there that can do the things. And I go back to one of the basic tenets of hiring people and attracting people is you offer them a good use of their time and you pay them appropriately for it. And it seems like neither of those things are happening. Um, do you have any idea, like other than the budget cycle, why is this this seems like it's done, it's easy, we should do it. Let's do it. Let's solve the problems. Let's make things better. Okay, one, two, three, go. What's the holdup?
Yeah. Well, again, I wish I could tell you. I wish I could be on here telling, hey, you know what, 15 months of having really close, there was no, I should just back up a bit. Like, new government comes. I started my term a bit early in June of next year to say, hey, listen, they're new government. Let's work collaboratively. Let's say, so, hey, we agree. Family medicine, absolutely critical. Foundation of healthcare system, we got to do it. We agree that we got to move to this funding model that's like an alternative funding model that's not fee for service. We work as hard as we possibly can. We get it done. And now I can't explain why they're choosing not to invest in that critical piece, why they're choosing not to value these physicians. And so, yeah, the numbers you're quoting, it's on, if you check out now on informed reform.ca that we actually have those stats now. It's 7 in 10 of all physicians are making plans in some way, considering a leaving in the next 5 years in Alberta right now with the way the state of things are. That's how bad it is. And in that group, I don't have the numbers in front of me, but again, almost half of them are making active plans to leave, and a lot of them are family physicians now. They have options. They can go to other provinces. They can do other work. They can work in other areas of healthcare that is not longitudinal family medicine practice, and many of them now are starting to tell me, like I'm starting to see them come. There's a couple in Airdrie. There's a couple in High River, the Premier's own home city. There's all around now. They've been holding out and waiting for hope. It's not coming, so they're making decisions to leave, and they don't want to, but they are. And so now the sad part is that's just retention. But if you want to look at recruitment, why would anybody come to work in this province when we're miles behind on the funding model for family medicine, for example? We're never going to be competitive with the rest of the provinces when we're trying to recruit into these communities. And then when you have these communities where if you have a community with 4 docs and you lose one, then you only have 3, then you lose another, you only get 2. Well, those 2 docs are trying to do the work of what really is probably 6 docs. You probably needed 6, but you had 4. Now there's 2 trying to do the work of 6 docs, and they just burn out, and it keeps on going. So no, I don't have an answer why government is choosing not to invest. And the one thing I want to put a fine point on this is they're choosing now to spend expensively and inefficiently. Every single time that we bring up why it's so critical to invest in family medicine, new funding model, and really invest in it, and we should have a strategy that every Albertan has access to primary care home and a family physician. Every time we bring it up, they're like, we already spend too much money on healthcare, so we don't have the money because the budget keeps going up, and so we can't spend on it. The problem is then what they're doing is they're spending on specialists like myself in a busy emerge department to do primary care, or they're having like cardiologists, like super specialized physicians doing blood pressure control in their clinics at a lot of more expensive rates than they would for if they did it in a primary care setting with a medical home. And we know this. We know that those costs are just going to keep going up and up. And then you add another 400,000 Albertans that don't have access, that can only seek care in those more expensive places. The costs are just going to keep on going. And as long as they choose not to act, healthcare is going to get worse and more expensive. And they're just not listening. They're choosing not to act.
I'm curious what you made of the announcement from Adriana Lagrange last week, where there were some numbers that she announced in regards to healthcare. I'm trying to remember what they are, but there's just so much paper. Um, that was a bit. $60 million
Yeah.
for a bursary and an attraction to get physicians to rural communities. And just doing some back of the napkin math, at best, that works out to 53 physicians potentially across the entire province of Alberta. Am
Well,
I
keep in mind, no, well, yes and no if you did it that way, but keep in mind this is a couple things. This is bursaries for students and residents, so training to become physicians. So it's bursaries to try to encourage them. So I should preface that any investment in rural healthcare is a good thing. So we need lots of it. But here's the scoop: that's Fed money. So again, government's not actually investing any of its own money. It's investing Fed money that's been federal money that's been long in the works, that has been in the works for over a year. 2, they're investing in the future of family medicine, which is a great thing. But who's going to train those docs? If you don't have family physicians working in the community to train these residents and students who are going to apply for these bursaries, and you don't have a stable environment for them to come into, you're kind of putting the cart before the horse here. Like you're actually investing in the future, but not investing in what we need right now so that we can have a future in family medicine. So again, any type of investment into rural care, this is good. So 16 million, it's bursaries, it's going to be divvied up. Some of it is also for first responders and some of these pieces in rural communities, which is, we need more of everybody. And we've always said that, but you honestly, there's two pieces there. If you don't have preceptors and physicians and people to train these first responders and these doctors, it's not going to work. Two, if you don't have a attractive funding model in the province, then maybe at best case, you might get some of these learners that you're going to train, and then they're going to go to BC or Saskatchewan or Manitoba when they get their degrees and go work in an environment that values family physicians and rural generalists. So you know, I do worry sometimes that these are just announcements for announcements' sake too. That they've been in the works for a while. They're federal money that's been promised a long time ago, but they're not getting to the root problem of the foundational issue around investing and stabilizing family medicine. And they would admit that they would say that if we asked them and challenged them directly, they'd say, no, this isn't going to fix our now problem. It might help us down the road in years to come, but that now problem, they're still choosing not to act. And I have to say it again. Like I talk to MLAs out there. So we know UCP, a lot of the MLAs are rural communities. We know they have rural constituents, right? Talking to these rural MLAs, I don't think they understand that family physicians who run their hospitals and do the bulk of their care in their community. And I don't think they get the urgency of that. The first places that are going to lose those physicians are the more rural communities that are already desperately struggling to maintain care. And they're just choosing not to act, and it's baffling. It really is.
Yeah, I did not realize that that was federal money. Thank you for that clarification because I didn't see any federal representation at that announcement. Um, and I want to get your thoughts on this because, and full, I should probably do a disclaimer here myself because I'm about to put on one of my other hats. Um, what I'm about to say represents only myself and not my employer, any other organizations, yada, yada, yada. But the announcement included the $800,000 to develop an MFR program, medical first responder program, and
Yep.
$600,000 to do the training of the medical first responders. And there's a part of me that goes, oh, that's cute. And I say this because, and again, I don't want to denigrate any first responder as a first responder myself, but it, that's a fascinating thing to put the money into. I mean, when people are experiencing health crises in rural settings, the better, the higher the level of care, the better. And when it was presented, oh, we've got these medical first responders, it wasn't delineated who basically will have first aid. Because
Yep.
when you're talking about medical first responders, they basically have first aid. And so cool, I guess, but not great.
But is it cool if there's no emergency department or hospital to take them to when they do the first
Well,
response? So
ambulance take them there. Like that's the issue.
absolutely. I know. So and again, I do want to say like anything that we're investing in rural and training and education, it's good. We need it, right? But is it held up as a solution for the current crisis going on? No, like it doesn't even come close to addressing it. And so the issue around just family medicine recruitment retention, huge, massive, and they know it and they admit it, and and that's going to have massive impacts on the rural and who's going to train them. But then the issue around acute care hospitals, who's maintaining the emerge departments, how are patients getting admitted, how are they flowing through the hospitals, huge crisis as well. This announcement last week, well, welcome, doesn't touch any of that. It doesn't address any of those. Like it's like Jasper's on fire and they're like, good news, we're going to train some firefighters, we're going to do some bursaries for firefighters for the future in southern Alberta. Like it's still a good thing to do, but is it going to put the fire out in Jasper? No, and they know that, right? And so I don't want to be critical of the investment itself, and absolutely the move around training learners in the rural, the universities they're going to do those pieces. Those are like the one in Lethbridge and South, and then the one in Grand Prairie and North. It's critical. It's huge. We need to do it because then those learners will maybe stay in those communities and do more rural care. But if you don't bolster the foundation of the docs and the healthcare workers who are going to actually do that training first, you're going to have no one to train. You're going to have no one there to do the training. I mean, so it is a bit of putting the cart in front of the horse, unfortunately.
The UCP has come forward with some solutions, and I'm air quoting this a little bit for our audio listeners. We saw out of Airdrie the announcement that the UCP actually approached a physician who works in Airdrie, who works in the Airdrie urgent care, and they gave him $85,000 to put together a business plan for what is, to my knowledge, and this is where I'm hoping you might be able to provide some context and clarity. It would be the first emergency room, in effect, because an urgent care is, for all intents and purposes, an emergency room that doesn't admit, they don't have the space to admit, they kick them to the hospitals. But for a lot of emergency care, urgent cares have the same diagnostic skill set and toolbox to work with as most emergency rooms do, certainly most rural emergency rooms for sure. And I'm not aware of anywhere else in the province of Alberta where there is the approach of, well, what if we did it private for profit? What if we did that for emergency care? There's no question the family physicians set up their own corporations and they do the business of medicine in order to help people, but also to pay the bills and their bills. And I assume put gas in the car from time to time. Um, but the proposal that's coming out of Airdrie is a privately run, for-profit urgent care with a primary care office on the second floor. That seems to me to be a major paradigm shift in the delivery of emergency medicine. And the reality is that Danielle Smith, just like a week and a half ago at one of her town halls, exclusive to UCP members, so town hall, that, if you will. But at one of her town halls, she doubled down and said, this is the model that we're trying. We're beta testing, in effect, in Airdrie, and we're hoping that we can roll it out across the province, maybe even export it to the rest of the country. That seems, I'm uncomfortable with that, but I'd like to know your thoughts.
Well, so I'm lost. It's a huge topic. So, a couple like so I don't. It's very shy on very specific details about that plan. So this is more in general around. So does that community need, improved access to family medicine specialists and urgent care? Absolutely. So what's the way to do that? So there's a couple pieces with this. First off, I would say right away that if government is giving money to, one of the things that makes me scratch my head and is I don't think our government fully understands that all the family docs offices out there in Alberta are all essentially doing this in some manner, like not necessarily running an urgent care. That's a step up. That's more urgent and emerge, but they're all running small family medicine practices. Some of them are even groups of 20 or 30. They have big infrastructure, lots of overhead and lots of costs. First thing I would say right away is all of those physician groups would be like, hey, Premier, hey, Minister, we want you to support our operational funding and our infrastructure funding like you're going to do for this one. Like, why? What? So I understand government right now has this idea that privately delivered, whether it's for profit or private public funded, just privately delivered is always better in some manner. I think they forget that family physicians are privately delivered healthcare out in the community. And that's part of what the entire model was about, was like help support the operations and infrastructure and overhead costs for these clinics. And I'm not talking like some of them are one single physician clinics, but lots are big clinics with lots of docs that are threatening to go under because they can't pay. So first off, why would they do it for just there and not all these other docs that are in line? Because as soon as they set that precedent, I would tell you every single one of those groups out there should be, hey, we want some government funding for operations and infrastructure too. Two, though, is this urgent care thing. So here's where the devil's in the details around. You have to think. So this government thinks that what they're going to do is create an acute care org, and every single provision of what type of healthcare needs to be done in the acute care world, they're going to have what they're calling clinical service providers. So a chartered surgical facility would be that. AHS would be a clinical service provider. Covenant Health would be, if this Airdrie clinic got off the and running after however long it takes to build, it would be a clinical service provider. So now think of this world where we're going to have, maybe dozens, if not hundreds of different clinical service providers. How are you going to coordinate that care? Like, what are we going to do around that urgent care center, for example? What if they do, conditions A, B, and C, but they don't do, D, E, F to Z? How does the government ensure that there's something in that area that will be able to do those kind of things, like heart attacks, for example? Are they going to do an urgent care that doesn't do chest pain? Or will it do chest pain? But then if it has some issues that the chest pain looks like it's a little more complicated, are they just calling an ambulance off the street to take them into a hospital and an emerge? Or what are they doing? And how is that care coordinated, right? And the problem is right now is there is zero plan for the coordination of acute care right now. In fact, Alberta Health Services used to do that. So however much you want to criticize Alberta Health Services in the sense of what it should have been, should there have been things improved with it, should have been optimized, absolutely, no question. But it was doing a very good job of coordinating all of the acute care that you need to get in Alberta. Um, with dozens and dozens of clinical service providers now, it's going to be a gong show. It's going to be, as an example, all of the AHS facilities have Connect Care. Well, with this urgent care, have to have Connect Care. Because if it didn't, and that patient went into urgent care in this facility, and then it has to be transferred over to a Calgary Emerge, for example, everything's going to be redundant again. You're not going to know any of the information. You're not going to be able to know what they did. You're going to have to repeat it all. Like, who's coordinating that? Who's making sure this is going to work seamlessly for the patients and the Albertans? And right now, I'll tell you, nobody. There is no. Alberta Health is taking this all on. The bureaucrats are drowning, just trying to refocus and dismantle and disintegrate our system. Nobody is looking out for the coordination of our acute care services in our province. And so, add this Airdrie urgent care center, and then add a whole bunch of chartered surgical facilities around it. Then add, well, what are we going to do for if you need some more emergency department, highest level care? Who's going to deliver that? Who's going to coordinate? It's a gong show right now, and they're just making it infinitely worse. And so, how would this all fit into the puzzle right now? I can tell you, if the premier is just spitballing at her meetings that, hey, this sounds like a great idea, let's get 10 of these up. Like, what's the evidence? What's the plan? How is it going to integrate with your EMS? How's it going to integrate with your emergency departments? How's it going to? What's the plan? Or are we just doing this off the back of a cocktail napkin? Because someone came with a really good idea. And again, I don't want to disparage the group in Airdrie. I'm not commenting on them specifically because it might be a great, amazing plan, and it might be able to deliver care in a unique way. I don't know the for-profit components. I don't know how they're adding private business into it. I don't know any of the details because nobody does. Is it going to be negotiated in the back room with government, a contract that no one may ever see even? And so, what are the details? What is the plan? How are you going to integrate it with your existing system? Like, that's a really long answer, Nate. But I'll tell you, like, this is a massive shift in how healthcare will be delivered in Alberta. And if they're just going to wing it and just do one-offs and say, "Hey, give this a shot, see how this is going to go," like, we could be in a lot of trouble. And then here's the one thing I want to just finish a little bit is Albertans should think about this. Do we want a really disconnected multiple providers everywhere and have our government sell off all these critical urgent care centers so they don't even own them? So now if we had 10 of these across the province, for example, they don't own them. They don't control them. They'll be at the mercy of whatever rates they set. They be at the mercy of, I didn't even talk about workforce. How are you going to coordinate your workforce in the Airdrie urgent care versus an urgent care that's maybe in Calgary versus how are we going to coordinate our workforce? Who's doing that? Is that on the responsibility of the new clinical service provider? Oh man, you're winding me up. I could just keep going here. Like, it's got so many issues that it's like, what's the plan? Show the plan if you're going to move in a direction like this. Like, and I don't believe the government has a plan. Like, if they have it, they have not shown it to myself. They have not shown it to the vast majority of my colleagues that would be like, integral in trying to coordinate some of this care. And that's scary.
Well, I guess the things that I bump up against is it seems to, I mean, not only as you pointed out, be creating a pretty major vulnerability because if Bob's Hospital Corp decides to say, "Hey, government, it's a real nice healthcare system that we own now. We'd like to talk to you about a couple of details on the next contract." There's not a whole lot of room for, well, no, we're not going to do that. But the other piece that I find alarming is, um, it creates the opportunity, which is again something to me that should be avoided, but it creates the opportunity to pick and choose who gets what. Like Airdrie already has an Alberta Health Services urgent
Sure.
care that Daniel Smith did a great job of denigrating at that same town hall. Um, and there will be this shiny new one that she paid to bring to life. And who gets the MRI? Who gets the fancy toys and who gets the scraps? And
Well,
that
yeah. What exactly? Why would this one be picked? Are they further ahead than others? Did they do a request for proposal? Like I don't know any of that, or is this just done because someone knows somebody? I don't know. So I'm not. I don't. That's where I want to be careful. I don't want to be caught talking very specifics about this group because it may be very well thought out and great plan. But here's a bigger piece that I would ask that I'd even focus on in Alberta, if you, this is what we really have to think about. So if you hear the for profit, anything that's profit related in our healthcare system right now, everybody should pause and think for a sec that every dollar right now, as long as it's publicly funded, every public funded dollar is a taxpayer's dollar. And do you want your taxpayers' dollars to be going to pay for profit in private companies, whether it's a single doc doing it or it's a big company like Shoppers Drug Mart or Rexall or whatever? Do you want your tax dollars to go to the government and then the government make deals with businesses and you're paying the for-profit component to make profits for companies? That's one thing that I don't think anybody is really thinking about as we're doing. So it's one thing if you're going to try to get a clinical service provider that does, a couple more cases for the same amount. That maybe, I don't know, that may have some benefit because basically then all your public dollars are going to pay for actual service delivery. But if you're using your taxpayers' dollars to pay for profit for somebody, why would we support that? Why would we do that? And then in addition, this is a scenario now where you're allowing government to not only take your money and decide how to spend it, but who to spend it to and what groups to make deals with and what businesses to make deals with. And so that's a gigantic shift in how we've ever done healthcare in Canada and or in Alberta. So if they're going to do it, they better be very transparent and very clear and tell people this is what's going on, and your money is going to make profits for big companies. I don't think a lot of Albertans would be on board with that and think it's a good deal. And then the second is, as they parcel off this, like you said, once the government, it's happening already with our chartered surgical facilities. So these are surgical facilities that are privately owned, delivering excellent care. But you got to keep in mind, anything that would kill you, they can't do it in those facilities. They have to be done in our big hospitals. So they can only do specific surgeries, and then they can say, no, we don't need to worry about any of this other stuff. That's a hospital issue thing, right? But at some point, when we have enough of them, government doesn't own or control them. In 5 years, 10 years from now, what they can say is, we either got to pay the rate that they're charging, or we got to walk away from them and build our hospitals again, right? So there's two big pieces that are gigantic. Do we want our taxpayer dollars going to big profit companies, and do we want to lose complete control over essential services like an urgent care center or a surgical center in our publicly funded healthcare system? Is that what Albertans want?
it's it's wild to me that it's even a conversation because uh and I it's a difficult line to walk because I mean even talking about the chartered surgical facilities, the I don't want to speak ill of any healthcare worker, period. And that's not what the intent of this conversation in any way is. I do have questions about things like, there's that orthopedic building up in Edmonton that was built in 2010. Beautiful building. It's got all the things. It has been closed for months because there's not enough staff to run that orthopedic service. And
Right.
that is like, why are we spending money pursuing these other interests when the reality is, um, we have the facilities that we can't even get the people to work in, and part of that has to do with the fact that there is some from what I understand, please correct me if I'm wrong, there is some form of brain drain going on where the staff are being, hey, you can go work at this facility, or you can go work at Bob's shiny surgical facility where they have an espresso machine. Um, that's a reality. Am I wrong?
No, I mean, it's absolutely the truth, and but it's even more than that. It's not even just a shiny espresso machine. So honestly, right now, and you struck me with what you said around, it's surprising to you. It's a dialogue or it's a conversation. It's not. I don't think Albertans know that our government's plan is to parcel off a whole bunch of this critical care and get it privately delivered, right? So even if it's still publicly funded, privately delivered. So, and I will echo what you said. It's not as the healthcare workers, the nurses, the anesthetists, the surgeons working in these facilities are phenomenal. But here's the setup, and what you said is bang on. We have such a workforce issue right now that you know what? It's any Albertan would understand this. Where would you work if you were just a nurse, let's say, and you could work 7 to 4, Monday to Friday, in a brand new facility with total scheduled care. Everybody's happy. It's a charter surgical facility where you have very clear lines of exactly what you got to do. Everybody's the patients you work on are relatively healthy, and they're in and out. Everybody, never have to work overtime, never have to go in at night, never have to go and be on call, don't have to do the crazy, really hectic, chaotic traumas and things like that. And you can make more money in that environment than you can if you work in our hospitals. And I want to be very clear. That's exactly what's happening now for our amazing OR nurses. They're making choices. Lots of them are choosing to be, yeah, I'd rather do the Monday to Friday, not miss time with my family, have a great quality of life and a great job. And they go to it. Same as our anesthesiologists. We're so short for anesthesiologists that now, and again, it's not anybody would choose this if your work environment is more controlled, you make more money. Because one of the really perverse things is that anesthetists, for example, if they do like 15 really quick cases, they'll make more money than if they did 2 long, call it 6 hours cancer cases. So now we're in a scenario where you mentioned the ortho in Edmonton, but in Calgary, for example, we routinely have diversions, meaning in our major hospitals in Calgary. So it could be the foothills tonight, maybe, that they don't have a team to do your regular general surgery emergencies. So like an appendicitis or your gallbladder or a tear in your bowel. They don't have a team. So if you go into the foothills, you'll get diagnosed by one of my emerge colleagues, and then they'll have to pull an ambulance off the street and put you in an ambulance, and then you go to the Peter Lougheed, and then you wait for a surgical team there, because they don't have enough staff in their hospitals in Calgary right now, as it is, because of the supply and demand for our anesthetists and the teams that help do the surgical, the pre-op and operative and post-operative care. They have lots of surgeons, but all the rest of the team. And so adding these CSFs now are actually draining it even more, that this will just get worse. And in fact, it'll get to the point now where we're almost in danger of inverting the priority curve now, where in Alberta, you're almost getting where it's not quite there yet, but it's close, that you could get your elective knee that needs to be done. It's a scheduled knee. You could get that easier than to get your appendicitis or your bowel perforation that might kill you. We're almost flipping the curve now. It's not quite there. And so some might say that's hyperbole, but if it carries on, absolutely. And the stats in Calgary for diversion, for example, like, it does blow my mind a little bit. Albertans don't have a clue that in our biggest city, in our province, in our biggest hospitals, we routinely do not have the surgical teams that are required to do the emergency surgical cares. And while that's happening, the government is currently considering adding more CSFs in Calgary zone, for example. In South Zone, where I am, half of our OR time in Lethbridge and Medicine Hat, half of our operating rooms sit empty right now because we don't have enough staff. And I hear good rumors that they're contemplating opening up CSFs in the South Zone. When it's very clear we already have that infrastructure, we don't have the adequate team to take care of it. So it again, what's the plan? What's your workforce plan? Like you mentioned the brain drain. It's a real issue. It's a challenge. So what is your coordinated workforce plan for acute care in this province right now? There is none. They neutered AHS. AHS has no say over it. Covenant Health, no say over it. They barely, interact as well as they probably should together between each other. Then you're going to add a whole bunch of CSFs, and now you're going to add some clinical service providers, like some more urgent care centers, and there is no CEO of the acute care org. There's no one organizing this stuff. It's chaos, man. It's bizarre.
Wouldn't it be, I mean, maybe I'm being a little simplistic, but if your goal was to provide Albertans the best healthcare possible, and you recognize people are looking at leaving the industry because they are unhappy, rather than build this whole parallel system that picks and chooses the patients that it's gonna take care of, wouldn't it be easier just to make the people happy?
Yeah. Well, yeah, you would. You know what? I mean, it sounds so silly to say it that way, but of course, like I think I don't think any government or really anybody really appreciated what the pandemic did after coming out of the pandemic, what it did to the global workforce for healthcare. So it's just and one thing that does drive me crazy is every time we bring up, well, we're having troubles here or that, frequently the government will be, well, it's bad everywhere in Canada. And in a way, I'm like, well, I do care about the rest of Canada, but when I'm talking in Alberta and talking to our Albertan government, I care about Alberta. I want to make sure that we're competitive, that we have our healthcare workforces valued, that they really are, that the people want to come and work here and be here and provide the care for the 500,000 people that we have flooded into this province in the last couple of years. Like we want to be a place that our healthcare workforce is happy to a degree, right? Like it doesn't have to all be joy, joy, love, love. Like I mean, it's work. Like we all have to do. There's some good stuff with our jobs, and there's some bad stuff. So, but the point being is, you definitely want a workforce that's valued. We definitely need to be competitive, and it's a really difficult workforce. Like so here I'll probably get in trouble for this, Nate, but I'm gonna tell you right now, as an example for our capacity and our like I'm just getting notified. So maybe it's not true, maybe it's fake news, or maybe it's a bit exaggerated, but like the Edmonton zone is not accepting any general internal medicine patients right now. I've just heard because they're at full capacity and they're capping because that's how difficult our teams are in the entire Edmonton zone. So if that is true, if someone's sending me that information saying that our entire general internal medicine service is capped and not has been activated, that they can't accept any more patients into the Edmonton zone, to put that in perspective, that is like all the major hospitals, Covenant Health and AHS, the sick patients that are admitted to the hospitals with strokes and with obviously there's all these subspecialties, but pneumonias and anything and everything that you're sick enough to be in a hospital, you're either taken care of by the hospitalists or the general internal medicine doctors. And the fact that we might truly be in a situation where general internal medicine is not accepting in the entire Edmonton zone tonight, that shows you how much we're struggling for our workforce and our capacity. So our ability to take care of sick people. And so then everyone will be like, what's that mean? It means anybody sick now out in the rural places will have to stay, or they'll have to fly over to South Zone or to Central Zone, or if they're really sick. And then it also means, though, that all the patients that show up in the emerge departments in Edmonton right now are going to just sit for days in our emerge departments. And then anybody that comes in that's sick in the waiting room, there's no space, it just backs up. So, that's the kind of situation we're looking at right now when we say there's acute care crisis going on in terms of our workforce. So, like I said, maybe I'll get in trouble for saying this on tonight, but if it's true, if it really is that our entire, so I've been saying for the last couple of months that we're extremely worried that we'll hit a point where we will have our general internal medicine physicians say, we truly have no more space. It's not safe. We can't take any more patients in the Edmonton zone. And if we really triggered that tonight, that shows you we haven't hit our really peak volumes of our respiratory illnesses that are going to come. We haven't hit a lot of our seasonal. And I always get criticized when we say respiratory, and it's like it's not a shift or a blame game that influenza or COVID, or we know every fall, going into winter, we get a huge spike of a bunch of different respiratory illnesses. We know this, and if we're hitting this before those spikes hit us, we're in trouble, man. It's the environment right now is truly in crisis, and unfortunately, our government's choosing not
I have a list that I want to work our way through.
to act.
You're,
I'm
you're
sorry, man.
so
I could talk forever on
so
all of these
tempting me
things, but
to mess with my list order, but I'm gonna exercise some discipline here because as much as and I mean, if that's true, whatever source it may be from, um, then it could be Twitter. I mean, who knows? Maybe it's coming from all kinds of places. It doesn't necessarily have to come from any official channels. But if that's true, then the healthcare system, like I and again, I'm going to put my other hat on for a sec. There's a turn of phrase that we use in the industry, and it's a turn of phrase that is supposed to be used exceedingly rarely, because at this point, when you start using these three letters, the rules change dramatically. The goals change dramatically, and those three letters, for anyone who's unfamiliar, I'm referring to are MCI or mass casualty incident. And that represents when the available resources of a healthcare thing are so overwhelmed that they cannot provide the care in the manner that would normally be exercised. This is where you literally choose who lives and dies. And if the healthcare system has become so overwhelmed, before we've gotten to the respiratory virus, influenza, COVID, RSV season, um, the implications of that are so dark,
they
and
are,
they're
and you know what, they are like, and so again, I'll government will jump on me and say I'm fear mongering and just trying to scare people, and I'll tell you that honestly, I think we have to be transparent and have these discussions because that's truly what happens. If Edmonton zone, so I'll say right off the get go, everybody working in that zone is amazing. They're going to do everything they possibly can. There's going to be surge pieces that we'll try to implement, we'll try to offload to other spots. We're going to work our hardest so that we take care of Albertans. And we always do. But if we are, there's no question. If Edmonton zone is capped for general internal medicine, for example, that is a mass casualty incident. That is we are in disaster mode because by definition of disaster medicine is that your demand way outstrips your supply, and that's no question what we're in. And so for me, sure, government could criticize me and say that I'm, fear mongering, just trying to scare Albertans. And I'll flip back and say, listen, the fact that we're in an environment like that and you're not talking about it and you're not actually acting and doing things that will make it better, that's worse. And I'll also say right now, the stuff that our government continues to do with the reorg and really kind of hammering on AHS and Covenant Health and the way things are going, like it's just making it worse. It's making it harder to deal with those kind of mass casualty incidents in an environment that's just so chaotic. So yeah, I mean, and I'll stick by my guns. Maybe they're going to come back and say tomorrow that, oh no, we managed to squeeze one more in and we didn't fully activate this or not. And I'm going to be like, you know what? That's insane that we were just one away then, right? Like that we're that's the environment we're in right now. So let's talk about it and let's truly declare it as a crisis that it is, and let's start working on some of the solutions so that, because you're absolutely right, if it continues on, and we all have scars from COVID, man. We had times where people who could have maybe been salvaged or saved in a different environment where we weren't in the peak of our delta waves and that we have people who died because we did not have the capacity to take care of them. We don't want that as a regular occurrence in our healthcare system. Nobody wants that.
okay. But what if, and hear me out here, what if instead of addressing the mass casualty incident that's ongoing on a semi-regular basis in the province of Alberta, what if the Alberta government instead put its energy into restricting access for healthcare for trans youth? That would help, right?
Gosh. No. And again,
There's my
that's,
pivot.
you know what, wasn't even that. So that's sad, right? So if we're talking about, so for 15 months I've been trying to advocate to Alberta, saying we have two big parallel crises. One is access to the foundation of family medicine. Two is our acute care stabilization in regards to things like if Edmonton zone is capped for all of general internal medicine. That's insane. Um, so for 15 months been talking about that. But what gets on the docket, what seems to be a top priority right now is continued dismantling of the system. A push towards a recovery Alberta ideology that is fully just recovery and very far on one spectrum and not looking at the full spectrum of care, and then trans care that is, honestly, like, how is that the priority? How is that our government's priority? Like that, it's making me scratch my head as well. Like, and some of the things that our premier has said around, trying to prevent things that have never happened before, for example, in trans treatment, getting some things wrong, like puberty blockers are not permanent and things like this. Like, it does make me wonder if this is the priority that Albertans share, and I don't think it is. I don't think if people can't get access to regular preventative primary care, can't get access to life saving emergency and urgent care in a timely manner, can't get access to cancer care or surgical wait lines, wait times. Every metric is objectively getting worse, and it saddens me that seems to be a top priority for our government right now. Is kind of ideologically driven, misinformed decisions around trans care.
It's wild to me because, and again, I come from a world of, well, what's the evidence? That's always the question. And there's always going to be, because of the vast depth and breadth of the ocean that is medicine, there's going to be little things that you're like, oh, I didn't know that was a thing, or oh, we didn't know how that worked, but it did. So cool. That's a thing that happens. But the fundamental question is, what's the evidence for doing the things? And as you highlighted right there with the trans care piece and the care for the gender dysphoria, there's no evidence to support the government's decisions that I'm aware of. And I find myself thinking, like, I don't think that that's a comfort. I don't think when you're standing over the body of your loved one who died from a pneumonia, or who died from a heart attack, or has permanent disabilities because of a stroke, I don't think anybody's going to be going, but you know what? We made those trans kid lives a little bit more miserable. Like, that's not a victory lap that anyone's going to be taking. It, it just makes me crazy. And I didn't swear enough.
No, it's tough, and honestly, it does amount to practicing medicine without a license to some degree now, because it's not. Why is the government getting involved in this stuff? This is truly now where, and don't listen to me. Like, I'm an emerged physician, so yes, I have some expertise and opinion on this, but listen to the people, the physicians that are doing this care, the physicians, the pediatricians, the psychiatrists, the children's. Like, I mean, it just makes me scratch my head why the government is getting and putting itself between the family, the patient, and the doctor, and the experts. It's sad. It's not something we should be spending our energy on.
No. And for anybody who's interested in hearing one of those conversations, we had a great conversation with Dr. Gillian DeMontany, who does provide that care and did an amazing job of myth busting all of the lies that unfortunately people in high positions in our government, cough the premier cough, continue to repeat for reasons that completely escape me. Bottom surgery isn't done. Period. Can we just
Correct.
stop?
Correct. It
Um,
isn't. And again, don't listen to me though. That's where it's like we have lots of excellent experts who spend their life studying and doing this care. Do we want to listen to some MLAs that got some advice, or do we want to listen to those experts? I would go with the latter for sure.
it's the evidence. I just love the evidence so much. Um, Here's a question that I'm curious, because again, it's another one that hasn't been well explained. It hasn't the plan hasn't been clearly labeled out. But one of the things that Danielle Smith has referenced is the forced treatment stuff, and she loves to go to, oh, there's this guy that was overdosed 18 times, and that's too many overdoses. I'm not sure what the acceptable threshold of overdoses is. I'm a little fuzzy on that, but um, if somebody overdoses that many times, then we have to take away their charter rights, and if we have to invoke the notwithstanding clause to do so, then we'll do it. I'm curious about that. Seems to present to me something of a moral dilemma for healthcare workers because if you, I mean, obviously there has to be some sort of reporting thinger that has to happen when you hit that. Oh, you've just hit your 16th overdose. Congratulations. We're taking away your rights as a human being. There has to be some sort of reporting matrix that works for that. And it seems to me that this is opening up, and I haven't seen any conversation about this, a huge door for moral injury for healthcare workers who don't believe in the revocation of people's charter rights just because Daniel Smith says so. Um, is that a conversation that we should have where you're now going to be asking the people who are actively resuscitating the people who are having overdoses to be complicit in some way, presumably, in this thing? Should that
Yeah. Well, no, like I don't, I actually, again, I don't know what the details are in any way because again, like it's a great, like it opens up. So, it's such a difficult thing because in Emerge every day, we make life or death decisions, and have to kind of try to, make sure that we can protect patients from themselves too when they are a danger to themselves or others from mental illness and things. But everyone should keep in mind that that's something that's very difficult balance, and it's the physicians who are trained and do this every day that are have that sliding scale. And but even then, when we do it, it just allows us to main like basically restrain the patient medically or physically restrain them so they can't harm themselves or others. It doesn't allow us to force treatment on them. It doesn't allow us to lock them up indefinitely. It doesn't allow us to do a lot of these things that we've never done in medicine. So I can't even I really worry and struggle with this because I can't even fathom how this would work. How do they know what happens with the patient physician privacy? How do they even know? And what are they going to like? Is it going to be at some point some healthcare worker has to violate that to tell the whoever it would be, the police, I guess. I don't know, right? Again, like how's all this work? And so again, I would say, what is the evidence? What does the evidence show around any of this? And then the second piece, though, would be, one of the things that I've heard from my colleagues again and again and again is that, if we truly looked at recovery and addictions as a spectrum and meet the patients where they are and have robust interventions and supports and help through all stages of that for all the patients that are presenting. That would be the first thing to do before you start looking at trying to think about locking up and or forcing treatment on a very small minority. Because you know what, again, it's so hard for me to comment because I don't know any of the planned ideas that they have for this, and I don't think they're intending to consult or get any opinion from the medical profession, from the AMA, for example. I don't know if they've just cherry picked someone that they like and got that input. I have no idea. But they're not coming to our like the AMA and our addictions experts and asking their opinion, or not aware of it at this point yet. But here's the problem that I want to say that does break our heart is that you see it, I see it, we see it every day, that there's just a catch and release environment already in medicine where people who desperately want help and we can't connect them into help. So let's focus on that. Like let's get some resources for these people that are really struggling with mental health or addictions who come into my Emerge regularly, and we try to intervene and try to get them into detox and supports, and there's not enough of those supports. They can't get into them for weeks. They can't get this, they can't get that. Like it does break my heart, and we see it all the time. So let's focus on that. Why wouldn't we put our energies on let's start with the people who are desperately requesting help, get them robust resources, and then we can look at those really small percentage that are really refractory to treatment and need extra help and resources, and then is locking them up the way to do it, or is there other ways? But I would say we should really, almost on a regular basis, I see people coming into Emerge, and my colleagues do, like, pleading for help on addictions and mental health, and we don't have the resources to help them. So let's fix that first.
Yeah, as you're talking about the consultation there, I had a little bit of a shiver because we saw with the FOIP that we did that the consultation that the UCP did after they announced their anti-trans policies was, so we're going to do it. How do you think we should communicate that we do it? The decision had already been made in the absence of evidence, no less. Um, and they did their consultation was simply, so how do you think we should announce this to everybody? And also, how do we hunt down the doctors that still try to provide this care? What are the penalties? What do you think, Joe Citizen with no legal background whatsoever?
And that rings true, because that was the exact same experience for the trans care as well. They didn't consult our experts. They brought them in and said, "How do you think we should inform everybody on these decisions we've already made?"
Yeah. Yeah, it's what on principle to me, I think that as soon as like, and I want to just explore this a little bit. I know that I'm pushing for time a little bit, but I'm gonna take everything I can get.
All
Uh,
right.
but when you're talking about the criteria that have to exist for somebody to be a threat to somebody else or themselves, like it's immediate.
It's
It's
very time limited. Absolutely.
so like I fail to see, in principle, the difference between somebody coming into an emergency room, having been resuscitated from an opioid overdose that's cut with God knows what, let's say metformin, because that actually is a thing that happens.
Okay.
And so their blood sugars are low. And then you, as the physician, say, "Hey, so is this the wake up call? Are you gonna stop using the drugs?" And they say, "Probably not." Okay, well, you can go about your day. Like you're not saying that you're deliberately doing things to hurt yourself. You're not saying that you're deliberately doing things to hurt other people. I think to me, the number of times, and again, not speaking for any organization that I'm affiliated with, but the number of times that I've gone to like the acute abdomen call and it's pancreatitis and it's the, 16th, 20th, pick a number, time that this person has had a pancreatitis flare up because they've been drinking. And you can take them to the emergency room, you can ease their pain, and you can say, "Hey, are you going to drink again?" And they'll say, "I really hope not." The odds are good that despite the negative reinforcement of all of that pain, that they will, because the underlying trauma, the underlying things that are driving them to that, and the physiological dependence to the alcohol haven't been addressed properly. And so to say to someone, "Hey, you're not ready to address those things. We haven't given you the resources to address these things under your own volition," because as you just said, there's a shortage of these, all of the things.
Yep.
So instead, what we're going to do is we're going to invoke the notwithstanding clause and take away your charter rights because we just really want the sense of control. And that's what it boils down to for me, is it feels like the whole thing is just about, I want control. I want to control what other people do. I want to control how other people express their gender because it makes me uncomfortable. Or I want to control what substances people choose to use because it makes me uncomfortable. And there's no question that those choices come with real consequences, and many of those consequences are tragic and they are sad. But I'm just not convinced, and I haven't seen any evidence to suggest, but let's force people and that'll work. And my understanding of the evidence is that it actually carries worse outcomes when you do that.
I mean, and even that, the evidence on that one's hard, because very few jurisdictions even try to do it, because it's so fraught. So I guess, I would just fall back on two things. One, I would say, because you're right, your analogy around alcohol, sadly, uh, you forever. I've done this for 24 years now. You can drink yourself to death in Alberta and Canada, and no one's ever had a discussion about intervening. And have I seen people drink themselves to death? Unfortunately, yes, like frequently. Probably, the opioid crisis has has been very acute in last while, but over the years, probably way more, probably alcohol abuse related issues over 25 years than opioid. But regardless, the point being is no one's ever intervened or decided to forcibly do anything around on that aspect as an example. But the second piece I would say again, which still does, have that moral distress and does, break, like it's hard on all of us, is that we'll see a lot of those people, even with alcohol related addiction or opioid related addiction, or like we'll frequently see them present to us in our hospitals, myself and my colleagues, like begging for help, and we don't have the adequate resources to help those people. So I'll just reiterate again that yeah, we're focusing on the wrong things. We truly are, and we should be, really focusing our energies on improving the system for the people that are definitely like lined up and queued and begging for it as a start.
I'm going to go to our last topic. And
Okay.
you tempted me, sir. Something fierce you did, because you were saying a few things about this. And I was like, oh, I wanted to, but I really wanted to save it for last because, um, we have seen from the provincial government some, let's go with inconsistent communication as to the reasons why vaccines are not going to be available in family physicians' offices. We are heading into the respiratory virus season. We have a main contender already. The last time I looked at the dashboard, there were no deaths from RSV. There were no deaths from influenza. 44 for COVID. Oh, it's running up the board. It is. Um,
Yep, it's out there. I see it.
I believe it, as do I. Um, I want to before we get, I want to give you the space to do the vaccine advocacy piece because I think it's so important. And unfortunately, I think that the government has introduced some barriers to entry by not making the vaccine available to physicians when it's going to become available. I want to get your thoughts on, like, to me, that is a big barrier to entry. I recognize that the vast majority of vaccines happened in public health clinics and in pharmacies as it is, but there's not an inconsequential number, particularly when we're talking about vulnerable populations, that happen with the family doctor. The decision, which I think I can safely call it, to not renew the contract with the company that was providing the logistics to arrange that by the government of Alberta seems to me to put more vulnerable people at risk and put more barriers for entry in place for any vaccination program. I'm just a hack podcaster who sometimes drives with the lights and the sirens. What are your thoughts?
You know what? Again, yes, is my thoughts. Vaccines work. Like vaccines save lives. They work. We know they work, and it's really sad. I'll start by it does sadden me. I keep saying sad. Actually, it's like wow, this is a bummer of a podcast because I'm disheartened with our province. I really am though because I think public health is almost dead in our province. Like it is, so at public health advocacy non-existent. It's our public health leaders, the few that are around that are still trying, they're seconded under Alberta Health. Their comms are written by Alberta Health. They can't even use the word COVID in their communications. There's so many things that doesn't make sense, and anybody that would be a good public health leader, the way that we've treated our public health leaders in this province, who would want to come work in this province and actually, really try to really robustly amplify public health messaging. Nobody. Yeah, it's sad. So just the fact that that alone is the starting point, that public health is dead in Alberta is, I want someone to prove me wrong, and I'm sure there'll be some public health docs out there who are still trying really hard, and they're like, Parks, like we're trying, but I mean, from a political point of view and our government's point of view, it's sad. And we're gonna have more E. coli outbreaks in kids. We're going to have more like really true contagious type illnesses, whether they're respiratory or not, because we just don't have a great, robust public health advocacy and system in our province right now, and we're going to feel those effects. And so that's my starting point, and it's sad, and we need to reverse that. Public health is really important. Public health is this big idea around preventative, community-based care, And you need advocacy to do that. You need people to be talking about how important it is to go get your COVID and your influenza vaccines. And then to go to your question, yeah, even if it's 10 to 20% that were administered by family physicians, those are trusted sources that can convince some people that, while you're at the contact, and if you're happen to not be the 800 or 900,000 that don't even have a family doc, you're lucky to have one, and you're at a visit and they're talking about getting your vaccines, and you're like, yeah, you know what, I should get it. If they've got it there and can deliver it, it removes so many barriers. You don't have to go somewhere else. You don't have to do an appointment. So yes, we should be doing everything we possibly can in this province to, be very transparent, educate around our public health, our vaccines, and remove all barriers to getting them. And then the last thing, I'll just cycle back to what I said. Like, we really are general internal medicine in the Edmonton zones cap right now, as an example. Like, the impacts of that vaccine hesitancy and any diminished uptake of vaccines in our province will affect every Albertan, because as more people get preventable illnesses that get sicker and need to be hospitalized because of them, it'll impact our surgeries, our cancer times, our emerge times. Everything gets crushed when we get these huge surges of sick patients in our system. And we take care of you whether you have a vaccine or not. And so I'll just say that it's something that's a really important topic for all Albertans to be thinking about, because it could impact you. It could impact, your loved ones. It could have major ramifications on so many people in the system, because we are doing poorly with regards to our public health messaging, our public health advocacy, our public health leadership, and our vaccine uptake. And it's sad. It's bad. It's like we're going back to the 1800s, man, where someone's saying, don't drink from that well, you're gonna get sick. And unfortunately, our government's like, no, I'm pretty sure it's okay. Go ahead and drink from the well. It feels like that some days.
Can't
Maybe
tell me
maybe
what to do.
that's too much.
I don't think it's far. I got one more question I want to ask you before I let you go. Because I think it's an important question. And as you said, I mean, I enjoyed tonight's conversation tremendously. I think our audience will as well. But here's my closing question. As an emergency room physician with over 2 decades of experience, no less, what's the thing at work that fills your cup the most, that gives you back all of the spoons? What is the thing, the case, the whatever that just makes you go, "Oh man, I love this so much."
Oh, you know what? There's never ever one thing in emerge, because we love doing so much of everything, right? So, but honestly, truthfully, that impact of the connecting with patients and actually making, because it's actually not all life and death in the emerge either. It's not like, the ER, like on the TV show where everyone's got, a spear through their chest and the spear's on fire even, and they're having a heart attack at the same time. Like, so yes, there is life and death stuff, but honestly, I think a big part of it is that, um, we're losing this a little bit, but that team based connectedness and the impact of being able to, work in a functional team and really impact people on a day to day basis. That's the part. Like, when I leave my, even as challenging as my daily, emerge shifts can be sometimes, usually there's a couple cases where I was really able to really connect and make a major impact with someone's life. Even examples of where the odd time when I see someone with opioid overdoses, for example, and you have those conversations about, this is going to kill you, can I get you help? And then the odd one that does, or they come back and they talk to you a couple months later where things are better and they're alive because of you. Those kind of things are what, really make healthcare, it feels, kind of gives you that, recharges you and rejuvenates you. And that's the one thing that it's a good point to end on again too, is that we are really struggling with our healthcare workforce right now. And I'll tell you, the people that are there are like truly working unbelievable, really working hard. And I always say, once you get into the system and get some access, you get amazing care. And people are there because they care, they really do. But it's getting tougher and tougher to do our jobs these days sometimes now. It really is. Like, sometimes those little death by 1,000 cuts make you forget to pause and be like, oh, you know what, that little that little 4-year-old that came in, panicked with an asthma attack that I was able to really quickly treat and get back home. Those things are, you got to remind yourself that it's worthwhile, right?
Has a helicopter ever fallen on one of your ER doctors just outside of the ER?
No. Why do you ask that? That's a very
That was
specific
the scene.
question.
That was the scene from the ER show. There was
That's
a
awesome. We did,
it
what,
was
about 30 years ago, it's odd actually, no, 35, I think, or some plane hit the Royal Alex, but so actually did. Yeah, it might have been in
close.
the early 90s, but a helicopter. That's awesome.
Yeah, no, it was an air rescue helicopter fell off the side of the building and just
It
like,
landed
yeah,
that. That's awesome. No, it's not. It's not always that dramatic.
very rarely in my experience. But
Yeah.
uh, Dr. Parks, I want to thank you so much for taking the time to chat tonight and having such a broad conversation. I love the unleashed, unrestricted conversation we had tonight, and I think it's fantastic. So thank you so much for that. Thank you for the work that you do, and thank you for the advocacy that you're continuing to do.
Yeah, no, thanks for having me. I should probably say at the end too, people don't think this is all. One thing I always say, and I think it's important to remember, is I may be accused of being partisan. In reality, there's only one government that ever runs the healthcare system at a time, and it doesn't matter what party's in there. You know, things are not going in the right direction for Alberta, so we need to try to work collaboratively with whoever's in government to fix it. So I appreciate the opportunity to just be able to talk about some of these topics so people are. I'm a big fan of transparency. I think people should understand what's going on, and you know what, I think I was a little bit negative tonight, but we have solutions. We are coming to government as a profession saying, here's some key things that would really help. And just unfortunately, at this point in time, they're just choosing not to act on the solutions. So hopefully we can break that bottleneck someday.
Maybe there's just too much paper.
Yes. and too many processes.
Exactly.
Yes.
Thank you so much, Dr. Parks.
Okay, thanks, man.
And that's it for another episode of The Breakdown. As always, if you appreciate the kind of content that we're trying to produce here, we would love nothing more than if you thought about signing up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab, where for just the price of a fancy cup of coffee a month, you can help us continue to produce this kind of content. Whether you're listening to the audio version of the podcast, in which case, maybe leave a review and a rating, or whether you're watching it on one of our streaming platforms, we want to say a big thank you to everybody who is part of the Breakdown's audience. And as always, take care of each other and keep the conversation going.